Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, where I'm also the Chief of Pediatric Cardiology. Thank you for joining me for this 299th episode of the podcast. I hope all enjoyed last week's episode on the topic of electrophysiology, in which we spoke with Dr. Vincent Palmieri of Emory University, when he spoke with us about the concept of whether or not it was necessary to use aspirin following left heart catheterization ablations. For those of you interested in electrophysiology and the concept of ablation for children, I'd certainly recommend you take a listen to last week's thought-provoking episode 298. As I say every week, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week, move on to the world of cardiovascular surgery for a very interesting editorial. The title of the editorial is Threats and Opportunities, Public Reporting in Congenital Heart Surgery. The first author of this work is Christopher Calderone, and the senior author, David Overman. When we're done reviewing this paper, one of the co-authors, Dr. Emile Bacha of New York Presbyterian Hospital, has graciously agreed to speak with us about this editorial. Therefore, let's go through the concepts of this editorial and then have a brief conversation with one of its important authors. This week's work is called a Congenital Professional Affairs Expert Opinion Piece in the Journal of Thoracic and Cardiovascular Surgery from January of this year, and a link to the document will be in the show notes. The authors are Christopher Calderone, Jennifer Romano, Robert Jaquis, Emile Bacha, Joseph Durrani, and David Overman, representing multiple centers in the United States, with Dr. Calderone coming from Texas Children's Hospital and Dr. Overman from Children's Hospitals of Minnesota. The work begins with the authors explaining that the core mission of congenital heart surgeons is to create safe and quality care for patients and families, and they review how public reporting in healthcare, and in congenital heart surgery in particular, has become a reality and fixture of the present era since dissemination of the STS risk-adjusted performance scores has become very common. In these scores, the observed versus expected mortality rates are reported. They explain how the impact of STS reporting has been substantially magnified by the fact that private enterprises are using these data as a central component of their rankings of congenital heart surgical programs, with the obvious most common one we are all familiar with in the United States being the so-called U.S. News and World Report. The authors state, and I quote, "Although public reporting is an important and useful tool to assist the specialty in its core mission, there are potential ramifications of public reporting that may be perceived as threats," and the authors explain that their purpose in writing this commentary was to examine the perils of public reporting and also to propose potential solutions, with the hope that the authors will provoke what they term spirited discourse on the topic amongst their colleagues, with the hope of ultimately coming up with better solutions to the problems associated with public reporting. The authors review the history of the STS database and how it was really designed to allow for internal quality improvement, and they emphasize that it was not designed to be a public comparison tool, and they characterize this public comparison usage of the data as a distortion of the original intent of those involved in developing this tool in the first place. They re-emphasize how the use of STS data in organizations like the U.S. News and World Report has only magnified this distortion, and they speak of the discontinuity between the original design and intent of this database and its present usage, and they explain that there is a need for expert and objective interpretation of the data in the STS so that the public who use these data can better understand accurately the meaning of the data. The authors explain how the use of these data in ranking systems has basically resulted in creating competition between programs to improve and then publicize their rankings, and how this can both make and destroy careers. They acknowledge that the public reporting has undoubtedly improved technical performance of pediatric cardiovascular surgery, and so they acknowledge that the marked overall improvement in outcomes seen in our field over the past 30 years are certainly due, at least in part, to public reporting. And they state clearly that this results in transparency that allows programs to evaluate their safety and quality in comparison with others, possibly allowing for opportunities to improve, and they further explain that full transparency is in everyone's best interest, most importantly, best interests of patients and patient families. However, the authors then review what they believe is a major flaw of public reporting, which is the imperfect nature of risk adjustment for congenital heart disease surgery, and they review how there are so many factors that can influence the outcome of a surgery, and how many are not accounted for in the risk-adjusted models used by the STS. They explain that normally they would not make a big stink about this. However, given the very important manner in which these data are amplified in the United States and used to demonstrate superiority of one program versus another, the importance of these deficiencies in the methodology becomes unnecessarily important and troublesome. They explain how the data's public reporting has resulted in what they call a, quote, near addiction to published rankings, and how, to quote the authors, when an institution's ranking goes up, celebrations that are eerily similar to a college football team winning the conference title occur, despite the conveniently ignored lack of statistical difference between rankings. And they speak of how when an institution's ranking falls, one surgeon was quoted as stating that it was as if a 5-alarm fire around here was present. And they explain how institutions will get together with teams to quote-unquote change things, despite the absence of statistically significant power to the findings of change. Importantly, the authors explain that the power of these rankings based upon these data is so great that it has many unintended consequences, including incentivizing behaviors to manage the numbers rather than patients, and it may make programs risk-averse in an effort to protect or even improve their rankings. With this as a background, the authors write, and I quote, "The objective of this publication is to examine the unintended consequences of the current public reporting and ranking structures, propose solutions, and initiate a dialogue within our specialty. The purpose of this discussion is not to evaluate whether we should have public reporting. We should be transparent. Nor is the purpose of this discussion to dissect the imperfections of the current STS congenital heart surgical risk model or the private enterprises that rank programs. They are imperfect, but the best we have at present. Accepting the concept that public reporting will not go away, we must ask what we can do as a specialty to protect our patients from a process that was initially designed to help, but has now created unintended consequences and may be detrimental to patient care." The authors then basically break the rest of the work into the discussion of what they believe are the 3 major unintended consequences of public reporting, and they offer their own ideas about how to solve or mitigate these consequences and improve outcomes. And let's go through them. The first aspect that the authors point to is that of assistance of underperforming programs, and the development of what they refer to as a clinical support panel. They explain how once a program has scored poorly in these rankings, there's typically nothing that STS does to help the underperforming center, and the center is basically left to its own devices to figure out how to improve. And they explain how deficiencies in resources, processes, and priorities can each affect outcomes in a negative manner. They explain that the surgeon at a given center may not actually have the leverage or power to effect change, and how the development of a trusted, responsible organization to oversee activities to improve could be helpful, and they speak of the development of multidisciplinary committees of experts, such as a clinical support panel that could perform an in-depth evaluation of a program and educate both people on the ground and the hospital itself. They explain how this sort of panel could provide objective evaluation of every aspect of care in a surgical program, including the surgeon's technical performance, and do so objectively and dispassionately. And they explain how there could be even a process for a program to be reevaluated to assess its progress, and maybe even a credentialing sign-off from the panel that initially assessed the program. They explain how this would result in a very substantial new responsibility for the sponsoring professional society, such as STS. The next aspect that the authors point to is the so-called risk adjustment orphan, by which they mean someone who has a significant congenital heart lesion but also has some other comorbidity that is not recognized or is insufficiently quantified by the current STS risk adjustment model. And the authors offer us examples like a conjoined twin undergoing a Norwood, or an infant who has lower extremity amputations and total systemic venous thrombosis who needs a minor cardiac surgery, or maybe ASD closure in a patient needing a liver transplant, just to name 3 examples. They explain that in typically smaller surgical programs, understanding the risks associated with such patients and the manner in which they might get dinged in the STS methodology, and therefore rankings, they will often transfer these cases to higher volume institutions as they can better absorb a mortality associated with these sorts of cases than a smaller program can. They explain that these risk adjustment orphans and the STS reporting structure have essentially resulted in worse care for these patients and risk aversion practices by programs to limit exposure of a program to an adverse outcome. The authors suggest a so-called mortality waiver committee that can review applications for waivers for these sorts of cases, and they suggest it could be completely blinded regarding institution and patient, and the patient could be submitted prior to surgery to avoid unnecessary transfers. If the committee were to consider this a risk-adjusted orphan and the patient were to die after surgery, the death could be a so-called waived mortality and not reported in the center's observed mortality statistic. They also state that having such a mortality waiver committee and data generated from it might help improve risk adjustment models for the STS in the future. Finally and thirdly, the authors speak of the possibility of development of designations for centers as an innovative treatment program center. They report how there is presently a strong disincentive to develop programs to help patients who have very high-risk problems, and an example of such would be pulmonary vein stenosis. Because these patients are very high risk, but not necessarily described in this manner in the STS methodology, losses of these very complex and sick patients can unnerve a center and dissuade it from managing such patients. The authors thus suggest that establishment of a system whereby there is actual incentivization of a center for development of these centers of excellence would be helpful through developing a program that might be termed an Innovative Treatment Program, or ITP, and they describe how there could be an oversight committee to evaluate and credential these programs, perhaps not unlike the ACHA for ACHD programs in the United States. These sorts of programs could be offered waivers of mortality for these sorts of patients in similar manner to the risk-adjusted orphan program that we just discussed. They also wonder if developing such a program could improve outcomes by cohorting the experience and the management of these high-risk patients. The authors explain that the only way these sorts of suggestions could ultimately be implemented would be to have a professional societal oversight and structure, and they would have to work closely with STS to accommodate this new reporting structure and work together to achieve the aims that they have been describing. And they suggest that the Congenital Heart Surgeon Society, or CHSS, might be the best society to consider taking on these committees and protocols given their acknowledged leadership in congenital heart surgery in the world. And so they conclude, the objective of this article is to provoke productive discourse focused on the management of the unintended consequences of public reporting that pose threats to our profession and compromise the care of our patients. As a specialty, we have an opportunity to redirect the power of public reporting to further incentivize provision of the best possible clinical care. As the leading advocate of congenital heart surgeons, the CHSS is ideally positioned to sponsor this discourse. Well, this is certainly a very thought-provoking work this week. The authors address things that I think all of us consider every day, and certainly as the co-director of a heart center here at Mount Sinai, I have thought about these unintended consequences perhaps more than I should, but in truth, how can I not? We all know that in the world of pediatric cardiology, our programs, rightly or wrongly, are all judged by the surgical outcomes. To a large degree, I've always felt that this is unfair, as there are so many things that go into surgical outcomes that lie squarely outside the pediatric cardiologist's hands. However, as we all know, this is clearly a team sport, and we all play our roles. I think that we're all aware that there is substantial degrees of gaming of the system as it presently stands, with smaller centers simply not being able to take on high-risk patients for exactly the reasons that the authors suggest. The implications of a single death in a center doing 250 cases annually are different than in a center doing 500, and it has always seemed unfair to me that centers receive demerits for having the courage to take on cases where we know the statistical likelihood of a good outcome is low, even if the likelihood of a good outcome without intervention might be zero. This is unfair and certainly is an unintended consequence of the present system, and I do believe that many of the recommendations that these high-powered surgeons have made are a very good starting point. Of course, as is always the case, the devil is in the detail, and the cost to start such panels is likely daunting, and the cost to centers would similarly be high, both to support these activities and to enact the changes that might be recommended. There's a lot to unpack, and so in the interest of time, I think we'll move forward to a conversation with one of its authors. Joining us now to discuss this week's work is its co-author, Dr. Emile Bacha. Dr. Bacha is the chief of the Division of Cardiac, Thoracic, and Vascular Surgery at New York Presbyterian Columbia University. He is a graduate of the Ludwig Maximilians University in Germany for medical school, and he completed residency at Klinikum Großhadern University Hospital in Munich, as well as residency at Emory University. He completed cardiac training at Massachusetts General Hospital in Boston, Massachusetts, and congenital fellowships at Hospital Marie-Lannelongue in France, as well as Boston Children's Hospital. It is a delight to have a prominent surgeon such as Emile join us this week to discuss these concepts. Welcome, Dr. Bacha, to the podcast. I'm here now with Dr. Emile Bacha of New York Presbyterian Hospital. Emile, thank you very much for joining us this week on the podcast.
You're most welcome, Rob. Nice to see you, and I'm very excited to be doing this with you.
Thank you. Very excited to have you. Lots of buzz on the internet about you joining, so thank you for coming and increasing the listenership. So, Emile, as I was reading this, I think I know the answer to this question, but I wanted to know first, what was the main motivation for you and your colleagues to write this editorial about a topic that has really been in all of our minds for the last 1 to 2 decades?
Yes, thank you, Rob, for the question. I would say the main motivation has been frustration with the metrics we're using for public reporting. Everybody is for public reporting. Nobody would argue ever that this is a bad thing. We're all behind this. It's important for the providers. It's important for patients, for families. But the metrics we're using are just flawed. And this is really, and not only are the metrics flawed, and I guess we'll get into this in a minute, but also the system within which we're working is flawed. We're letting third-party providers who really don't have any business in not good understanding of what we do, decide, who's good, who's not good, depending on what they, decide. So this is the problem.
I see, yeah. No question. That's, I'm sure, rings true to most people who are listening today. In your paper, Emile, you and your co-authors suggest a few so-called panels, outside panels, that might help centers improve. And one of them that you describe is a so-called clinical support panel, which would be sort of a panel that could come in and potentially assess and then help an underperforming center to improve. I'm wondering if you think that there would be acceptance of such a panel, and what would you anticipate would be the obstacles to developing such a system of oversight for underperforming centers? To me, money definitely sounds like one obstacle, but I'm wondering what your thoughts are on this.
Yeah, well, money is always an issue, obviously. Who's going to pay for this and who's going to pay for travel and so forth. But as you know, currently, we don't have a good system to deal with underperforming centers. And an underperforming center can have many, many different causes for the underperformance. I mean, typically the surgeon is being blamed, but often it's not the surgeon. There are other things that are at play here. Mm-hmm. And there's just simply no mechanism that we could invoke that evens the playing field, meaning your center and my center and any other center could be calling the same number, so to speak, and asking for a review by an organization that's impartial, well-respected, and has the gravitas that it is believed by people. And so that was the origin of this idea. A lot of us have done reviews. Those are sort of privately organized reviews of programs.
Yes.
They're a bit hush-hush. Nobody really, often the report ends up in a drawer somewhere or is used for some administrative secondary purpose that you weren't really aware of when you did the review. And so such a mechanism would really, as I said, it would sort of air the system. It would be open to everybody to see. These are the metrics we're using. These are the people that are doing it. And it's an official thing. That would be very good. And then the final thing I want to mention is that the organization best positioned to do this, although I am currently president-elect of the American Association of Thoracic Surgery, so the AATS is very, very well positioned for this. However, the society that is most sort of ingrained in this is the Congenital Heart Surgery Society, which is the only society that deals exclusively with congenital heart surgery problems and outcomes and science and so forth.
Yeah, and your group definitely makes that point in the editorial comment. You know, Emile, although public reporting has been associated with improved outcomes, it's pretty unusual that there are statistically significant differences observed between centers, and most people, including doctors, are not particularly savvy with statistics, and as a result, there's this sort of general tendency to look at the, for lack of a better term, standings, as one would look at a baseball standings and assume that the first place team is better than the second place, and even if the sample size is way too small to demonstrate meaningful differences. How do you think STS and other, shall we say, amplifying organizations, to use your term, like the U.S. News and World Report, should better explain these outcomes that they report so that people don't draw unfair or simply wrong conclusions based on the data that are presented? And I'm wondering if you think it's even realistic at this point to expect that we can undo this tendency to just look at the order and read more meaning into these values than maybe really there is. Has the horse left the barn, as it were?
Rob, I'm an optimist at the core of my being, and so I wouldn't say the horse has left but the barn. I think the horse is maybe halfway outside the barn, but not quite. And I think that this is actually a very important topic because it does cause trouble at many levels. I mean, let's take U.S. News. STS, by the way, I wouldn't call it an amplifying organization just because they do not. The U.S. News and World Report uses publicly available data typically that the STS provides. So, but U.S. News and World Report definitely is an amplifying organization, and exactly, you really said it very well. You know, if are you better if you're number 2 this year versus whoever is number 3 or 10 versus 11, etc. Programs move all over the place on those rankings. We've gone from number 5 to number 20 back to number 7. I mean, it gives you a headache, to look at this.
Right.
And the problem here is, number one, the sample sizes are very, very small. The heterogeneity of our specialty is so large that it is statistically impossible to draw any meaningful conclusions from these kinds of studies. Furthermore, the fatal flaw really is the usage of the stat classification in this particular situation. The stat classification was developed to do a very broad statistical analysis of congenital heart surgeries, absolutely not to compare one program versus another.
Yeah.
So this is, you cannot use, and the worst part is using stat classification to criticize a particular surgeon, saying, look at this surgeon, he or she is terrible at stat 4, stat 5, because that is a complete travesty of the stat classification. Those are people who do not understand how the stat classifications came about. I'll give you an example of the travesty of what we're dealing with now. And it's not, I mean, it is statistically speaking, it is sound. It does have meaning, but it has only meaning in big systems. At this point, with the current stat classification, and arterial switch, let's take arterial switch operation, something very confined that we all know what it's about. Arterial switch plus arch repair has the lowest stat classification of all arterial switch options. It's lower than the simple arterial switch.
Why is
arterial
that?
switch, because statistically, it was found that the mortality after, I'm kind of explaining it in a simplified way, but nationwide, arterial switch plus arch resulted in less mortality than simple arterial switch. Maybe it's because ASO and arch was done at bigger centers with more experience. Maybe simple arterial switches had more risk factors, which we haven't even talked about, and they're very, very poorly. The risk adjustment is a big, big problem.
Yeah.
But we're not even talking about risk adjustment here. We're talking simply the operation. So it goes arterial switch plus arch, followed in increasing stat, followed by arterial switch, followed by the way, aortic arch, simple aortic arch, is a higher stat than arterial switch and arch. Go figure. Followed by arterial switch plus VST, followed by arterial switch, VST, and arch. And nowhere do you see coronary, risk stratification or anything like that. So, I have a lot of respect for the statisticians who worked on the stat classification because there's been a lot of work done and it's good stuff. But it has been perverted in using it for such things as the U.S. News and World Report rankings. And so the final thing I would say is that has the horse left the barn? I mean, I think as a profession, and we meaning pediatric cardiologists, pediatric cardiac surgeons, we are one of the closest aligned professions that exists in any specialty. Yeah. And it's a beautiful thing. And we should really talk about just rejecting incorrect metrics that are being used and that result in so much, headaches and careers being lost, and also risk avoidance, meaning patients can be hurt because you're simply not wanting to operate on high risk patients.
Yeah, I definitely think that I'm on the New York State Cardiac Advisory Committee, and it always comes up every year or so. How are we going to do our statistics? And the problem is we can never really do anything more than has been done for the last 20 years because of exactly what you've described, which is that the profound heterogeneity of our disorders means that even the busiest hypoplast center maybe only does 15 or 20 in a year. Yeah. And so how on earth can you make comparisons between groups? And I think it's really remarkable that you and your colleagues have, shall we say, taken the bull by the horns and sort of suggested that it's time enough that we should stop allowing outside organizations to use our data improperly to make these types of comparisons. I just, I think as the chief of cardiology, every year I'm told how these, I forget the name of the organization, but, people sign a piece of paper that says how their experience was when they went to seek the cardiologist. And, there might be 37 people who filled it out that year. And the average in the United States might be 97% of pediatric cardiac practices get high grades, a 5 out of 5. Mm-hmm. And if your year 2 people put a 4 out of 5, then you're at the 94th percentile and you're doing terribly, and so it's, and no matter how many times I say to administration, this is not statistically significant. This is literally 2 people who had a bad day, and I think that in a very real sense, what we're discussing today on a much larger and more important scale is exactly the problem, unfortunately. Yeah. Well, for those in the audience, it's fairly late, and Emile was really nice to give us time. I'm very appreciative. So I'm going to finish up. This article came out about 6 months ago now, and I'm wondering what's been the response. Have you and your colleagues noticed any practical movement to enact or even discuss in a formal manner some of the suggestions that you, Dr. Calderon, and your other colleagues have come up with? Some of them seem so obviously excellent. What's going on with this?
Yes, I think the proposals that we put forth, the 3 proposals that we put forth are good. They're a starting point. We're obviously not stuck on them. We are wanting to discuss this issue. We've had, I'm sorry, the dog is barking.
No worries.
But I am, I want to give credit to Chris Calderon in particular, who really is the force behind this. I'm just a passenger, and I'm an interested passenger in this, but he's really the one who's pushed this. Now, in terms of the response, we have had some responses. There's been some discussions going on, but most importantly, right now, there's a significant discussion going on within the CHSS about how to do this and how to implement some of these things. And as you know, these societies don't really move very fast, but we're talking about it, and we're trying to do something about it. The question is, should we collaborate with one of your organizations, the pediatric cardiology organizations, to do this? Because ideally, we wouldn't want to do it on our own, i.e. the surgeons doing this on their own.
Yeah, I definitely think, though, that it's extraordinarily admirable what you, Dr. Calderon, and all of your various co-authors are trying to do to sort of grab hold of our own statistics and try to reinterpret it properly and not look for things that aren't there also.
Right.
So, Emile, I can't thank you enough. Thank you very much for joining the podcast this week. This is episode 299, and congratulations to you and your co-authors in starting what I hope is a movement to improve analysis and evaluation of our programs to help raise the water and all the boats in the ocean, as it were.
Yes, I couldn't agree more. Thank you very much, Rob, for doing this.
Thanks a lot, Emile. Well, I think that Dr. Bacha shared his thoughts on this topic quite well tonight, explaining that the goal of these authors is not in any fashion to stop public reporting, but instead to work on ways of better utilizing the data properly to help all of the programs to improve, rather than compare them to one another. I agree with Emile that this is going to be a very challenging undertaking, given our penchant to compare and rank things. Who's the best center fielder of all time? Who is the best boxer of all time? Who's the finest surgeon in the world? And the list goes on and on. Rather than this sort of endless comparison, it seems clear that instead of comparing ourselves using flawed data analysis, we should use these important data from STS as a starting point to inform approaches to improving all programs, and in so doing, improve the surgical and other cardiovascular care of children and adults with congenital heart disease. This will certainly be a daunting task, but I'm sure that with the powerhouses who are authors of this week's work, change is likely coming soon. I'd like to thank Dr. Bacha for taking time from his very busy schedule to speak with us this week on the podcast. To conclude this 299th episode of Pediheart Pediatric Cardiology Today, we celebrate the birth of the wonderful American mezzo-soprano Shirley Verrett, who was born this week back in 1931. Ms. Verrett was an anomaly in opera, as she was both a mezzo-soprano and soprano, and she fought racism her entire operatic career as an African-American singer. In the early 1960s, Ms. Verrett was invited by the great conductor Leopold Stokowski to sing with the Houston Orchestra, but the orchestra board members refused to allow a black artist to sing with the orchestra. Despite the racism she encountered, Ms. Verrett blazed a path for many other wonderful African-American artists in the coming decades, and she went on to have an extraordinary career, singing in all the major opera houses in the entire globe, including New York's own Metropolitan Opera. Today we hear Ms. Verrett sing the wonderful mezzo aria Voi lo sapete from Mascagni's Cavalleria Rusticana. Thank you so much for joining us this week, and thanks once more to Dr. Bacha for joining us as well. I hope you're as excited as I am for next week's milestone 300th episode. I'll see you then next week.